Good afternoon, everyone. Now, how do I read a clinical trial? Now, title is not how to read because there are multiple ways one can go about it. And what I'm going to do is to, in the first part of the talk, talk about some principles that principally will deal with p-value, confidence interval, and estimates, point estimates, how to read that. And in the second part, I will take you through important papers in our field and how do I read that and how to carefully read it. So, do's and don'ts of p-value, point estimates and confidence interval. Then is there a solution to the problems that people have multiple times highlighted about the p-value, and then reading a RCT. Now, the gentleman on the left is Mr. Fisher, who in early 90s introduced p-value, and one on the left are Neyman and Pearson, who pioneered the hypothesis testing in early 90s. I never knew their faces. I don't think anybody of us is expected to. When Googled their photographs, I could come up with this. They are looking very happy. They must be resting in peace now, but all of us are not at all at peace with their. So let's start with this. Most of us are aware of this SMART trial. This was a randomized controlled trial evaluating two types of fluids with regards to their impact on the major adverse kidney events. Over 15,000 patients randomized, and these were the outcomes. There were fewer events in the balanced crystalloids and a p-value of 0.04. So which of the following is true about this p-value of 0.04? Probability that SMART is a false positive study is 4%, or whether null hypothesis is rejected. Alternative hypothesis that balanced fluids are better is true, or possibility of falsely rejecting null hypothesis is 50%, and based upon these results whether we should be using more balanced fluids. We will come to this question back again after some time. So I will take you through simple understanding, that is traditional understanding, which most of us today have of the p-value in next few slides, but remember that there is only a difference of TON between being simple and simpleton. So let's have this hypothetical RCT. Nephrologists are better hypertension specialists than cardiologists, and I want to conduct a randomized controlled trial, and null hypothesis here is devil's advocate. He says there is no difference between proposed or conventional treatment. Both of you are equally good or bad. So there is no difference. So I have to disprove or reject null hypothesis by doing a randomized controlled trial, and I conduct this pragmatic trial of 500 plus participants, 5 hospitals, randomizing patient to cardiology services versus nephrology services, and I see at 3 months who is treating blood pressure better. And here is the trial results. At the end of 3 months, patients treated with cardiologists have 138 systolic, those with nephrologists have 135, and p-value is 0.01. So what does this 0.01 mean here? If both were equally good, chance of you finding nephrologist better is 1%. Cardiologists are not happy. They wanted to do it themselves, and they conducted a trial whose summary statistics is this. Their blood pressure difference is 4 mm in favor of cardiologists, and 0.009 is the p-value. So this means if both were in fact equally good, chance of you finding cardiologist better is just 0.9%. Then nephrologists are not happy. They say we will conduct an independent trial, and here there is no difference. P-value is 0.12. If both were in fact equally good, chance of you finding cardiologist better was 12%. That is very high chance, and we reject null hypothesis here. So what is p-value? What is the probability of results that you have found if null hypothesis were true? If there was no difference, what is the likelihood of you finding a difference? So in our case, in this trial 1 result, nephrologists are lowering blood pressure better, p-value 0.01. What is the probability of finding that nephrologists perform better when in fact they are not better. That is only 1%. So why this 0.05? Because we have assumed that chance of less than 1 in 20 is a small enough risk of being wrong. That's what we have empirically assumed, everybody of us, and then we declare that moment we get there, results are statistically significant. But we may get wrong with this approach on two sides. One, you may get a statistically significant result, 0.05, when in fact there is a difference, or when there is no difference. So you may find a statistically significant reduction in the blood pressure when there actually is a difference in the treatment between two specialists, that is true positive. But sometimes you may find a difference when in fact it is not there, that you have committed an error called as type 1 or alpha, or you may find that there is no difference, 0.05 and above p-value, but actually there was a difference. So you couldn't detect this difference, you were false negative, that is type 2 or beta error, and there is a possibility that you may actually find that there is no difference and there is really no difference and you are true negative. So it's something similar to the diagnostic testing. But why do we error? Because of two occasions, and these errors are inherent to the hypothesis testing. First is the random error. Random error is because of inherent variability of the measure that we are assessing as outcome, here blood pressure can vary because of random error, and there is no reason for it to increase or decrease, and this error cannot be controlled, and that is random error. But other type of error is non-random or systematic error, we call as bias. This may get introduced because of several reasons, because there may be more senior cardiologist at the clinics, or nephrologist may be dealing with more severe hypertension or such factors, and they can introduce an error that is bias or systematic error. So it is very interesting or important to understand that goal of hypothesis testing, we are not addressing a question whether chance is responsible for the finding. This is very commonly misunderstood purpose of the statistical testing. We are not asking whether chance is responsible for the finding. We are asking how likely random variation is to account for the finding under the particular circumstances of the study. So coming back to the question we asked about the SMART trial. Option 1 is probability that 0.04 means false positivity is probably 4%. So p-value is not type 1 error. So this is one of the most important misunderstanding about the p-value. It is not the false type 1 error or false positivity rate. How does p-value relates to type 1 error? There is a relation, but it is not type 1 error, because p-value is estimated assuming that null hypothesis is 100% true. It just tells you how consistent is your data with true null hypothesis, whether it is consistent, whether it is inconsistent. So it cannot determine which of the two possibilities are there. If null hypothesis is true, but your sample is such unusual, distributed, or your random sample error is such that you have detected a difference, or it doesn't tell you whether it is more likely that null hypothesis is false. So 0.04 incorrect interpretation is there is 4% chance of making a mistake by rejecting null hypothesis. Correct interpretation is that assuming that there is no difference at the population level, you would obtain the observed effect or a larger effect in 4% of the studies because of random sample error. It is little confusing, but bear with me for some time. So coming to the next option, that is null hypothesis is rejected. Do we reject null hypothesis because 0.04 is the p-value for this trial? So p-value is likelihood of your data if there was no difference. It cannot reject null hypothesis because p-value is estimated by assuming that null hypothesis is true. It doesn't tell anything about alternative hypothesis. It just tells probability of your data if null hypothesis were true. It doesn't tell anything whether it is alternative hypothesis or some any other hypothesis is true. You will be surprised to find this, that possibility of falsely rejecting null hypothesis in this instance of p-value 0.04 is almost 50%. We'll come to there. So this was done by the bias method, and you can see here, if you have a 0.05 p-value, it is not 5%. You can have a minimum of 23% error rate and commonly 50%. Commonly 50%. With 0.01 it gets better, but still there is a significant chance of committing error, typically about 15%. So p-value gives you a false impression of considerably more evidence against null hypothesis than is warranted. Am I clear here? So p-value is telling you something that is, we are interpreting out of p-value something that p-value doesn't or can't tell. That's why we need better measurements to make decisions, which probably will be of more clinically relevant to the patients also as well as clinicians, and that's why we have point estimates and confidence intervals. As Srijit has already introduced this terminology, they are estimated variously as odds ratio, risk ratio, hazard ratio, etc. They put emphasis where it actually belongs. We are interested in knowing how well the treatment works as compared to the placebo or as compared to the conventional treatment, how much reduction in the outcome, how much benefit in the outcome. So that is what clinician and patient is wanting to know. Also, confidence interval will tell you how precisely this effect is estimated. Now this is a cartoon about confidence interval. Temperature tomorrow can be as low as 40, as high as 200. So this guy is never wrong. So confidence interval can be sometimes very wide, but wider the confidence interval, imprecise is the estimation of the effect. So this is the range of value within which true effect lie. 95% of the time, if you repeat the experiment 100 times, on 95 occasions, the true effect will lie between the upper and lower bounds of the confidence interval. And there is a formula, it is not very difficult, we will come to this again. So this is estimated by basically a sample mean, and upper and lower bounds are calculated by Z is the confidence level. Typically it is set at 95%, but we can set it at lower or higher, usually 95%, and then standard deviation divided by square root of your sample size. So this is a question, larger sample size, what is not true, I think we will skip, we will go to the another example in the trial and then come back to this confidence interval question. But we can have various permutations and combinations of effect size with confidence interval. You may have a big effect that you have found in your study, but confidence interval will be very wide. You may have a big effect and narrow confidence interval. You may have a small effect and small confidence interval. So any combination and permutation of these two can happen. So when we want to ascertain the clinical significance of the statistical results of an experiment, these are the steps I would follow. This step 1 is often missed, and that is probably, in my opinion, the most important step. What do you think is the clinically meaningful difference that you are looking out of the intervention that is being evaluated in that particular patient population? Then you go and check what is the effect size that trial has observed and how precisely, that is, what is the confidence interval around that effect size. Now, take for instance a drug A. It claims to reduce the risk of contrast-induced nephropathy after coronary intervention in patients with CKD. Now, this is a very high risk population, already CKD and coronary intervention risk of AKI, and you believe or estimate, judge, that 10% reduction would be at least, it will be a significant reduction if a drug does that. And we have 4 hypothetical trials. Now let's look at trial 1. It has 800 participants. You can see the square, that is the point estimate, 20% reduction in the risk of contrast-induced nephropathy. The 0 is the point of no difference, p-value. The moment your bar, that is confidence interval, crosses that line, this p-value will be insignificant. This blue line is the clinically meaningful difference that you have believed a 10% reduction would be considered as clinically meaningful reduction in the risk of CIN. And now this particular trial enrolled 800 patients, found that 20% reduction has occurred and it can vary from 15% to 25%. Now, these results are very significant because they are not only statistically significant, 0.05 and less, they are clinically also significant because your predefined 10%, it has reduced the risk more than 10%. Now, study B has a slightly smaller sample size, say 400. It has also detected the same point estimate of 20% reduction, but see the confidence interval. It can range from 5% reduction in the risk to 35% reduction in the risk. So it is less compelling than the study 1. Study C has still lower patients, say 200 patients. Again the 20% reduction, but this time these results are not only clinically insignificant, but even statistical significance is not there because p-value is more than 0.05. The bound of confidence interval is crossing the point of no effect. Study D has large number of patients. We have some 900 patients here. You can see here there is 5% reduction in the risk of contrast-induced nephropathy. Very narrow confidence interval because large number of patients are there. But these results, although statistically significant, because probably we have studied large number of patients, they are not clinically as compelling. Now let's come to the another important trial in our field, that is SHARP trial. So most of you might have read it, sometimes somebody must have talked about it. Lipid lowering in patients with chronic kidney disease, and this trial was the basis of KDIGO guidelines on the lipid management in chronic kidney disease. This is the summary results of the trial. You can see here the bottom diamond, one is the point of no effect. There is about risk reduction of 0.83 is the relative risk, and about 17% reduction in the primary outcome of many major atherosclerotic event. So these results were considered as statistically significant. Now I will come to another trial, CAPTAIN trial. This trial is very little discussed, at least in nephrology circles. This was a trial of whether withdrawing renin-angiotensin inhibitors before coronary intervention does any good in terms of preventing contrast-induced nephropathy. This was published in American Heart Journal 2015. 208 patients either withheld RAS blockade or continued, and primary outcome was AKI, and these were the results, 10.9% versus 18%. But p-value was 0.16, hazard ratio of 0.59. So if we go by the null hypothesis, interpretation of p-value, there is 16% chance of obtaining this or more extreme difference in the outcome when actually there is no difference. That is what is our interpretation of this p-value. Now look at the SHARP trial data here. Primary outcome occurred in 11.3% versus 13.4% of the patients. P-value was highly significant, 0.002, and risk ratio was 0.83. So interpretation here will be there is 0.2% chance of obtaining such a result, a difference in the outcome, when actually there was no difference that was really there. So does this mean CAPTAIN is a negative trial? Whether SHARP trial results, we should be using statin in most patients with CKD. Clinically meaningful reduction in the cardiac outcome is shown in the SHARP, or clinically meaningful reduction in the CIN has occurred in CAPTAIN, or SHARP is a positive trial. So this is called as p-value function. Now bear with me, most of us are, we hate mathematics, but still I will just take you through this p-value function of these two trials. On the right is the SHARP and on the left is CAPTAIN. One is the point of no difference, and as you can see here, in the SHARP trial, this confidence interval is very narrow, and p-value is significant because it doesn't cross the point of no effect, as against in CAPTAIN, although there is a large reduction, but p-value is insignificant. Now estimating the effect, you can see here, if you go by the hazard ratio, there is 41% relative reduction in the risk of CIN in the CAPTAIN trial. But in SHARP trial, there is 17% reduction in the occurrence of major atherosclerotic event if you go by the risk ratio. Now, if you calculate numbers needed to treat to get the desired effect, we need to treat 48 patients for 5 years with simvastatin plus ezetimibe to prevent one major atherosclerotic event. For coronary event, you will have to treat 250 patients for this duration, and these are the numbers for other outcomes. As against, you need to withhold ACE or ARBs in 13 patients to prevent one instance of CIN. So this point illustrates what is the difference between the statistical and clinical significance. This also has to be borne in mind. What is the cost of the intervention, duration of the treatment that is needed. You can see here a lot of patients stopped the drugs. A lot more patients stopped the drugs as compared to the placebo, and these were the number of comparisons that were made. I don't want to, or you will not be able to go through it, but when you do the multiple comparisons, you need to correct for it, and a probability of obtaining at least one p-value less than 0.05 will go on increasing the moment you do lots and lots of comparisons. 15 different comparisons were made, and there was 54% chance of finding at least one significant because of just chance. So, and sharp trial investigators have published all their results pre-specified. Not everybody will do that, and somebody will publish only the positive results, and that is called as file drawer problem. Here we keep all our insignificant results. So what are the problems with P? P, problem 1 is that it attempts to reject null hypothesis without telling you whether alternative hypothesis is true. It doesn't do anything about alternate hypothesis. So we want to we are actually interested in alternative hypothesis, whether the intervention works or not. So we generate a null hypothesis. We say that experimental hypothesis is wrong. Then we calculate the probability of our data if null hypothesis were true. If it is 0.5 and less, null hypothesis is rejected. Experimental hypothesis must be true and accepted. That's how we traditionally do it. If it is more than 0.05, null hypothesis is not rejected. Experimental hypothesis is neither accepted nor rejected. But null hypothesis is unlikely but not rejected when it is 0.05, because null hypothesis p-value cannot reject, and we assume that alternative hypothesis must fit our data better. So p-value is 0.05 and less tells likelihood of observed data occurring if null hypothesis is correct. But what is the probability of alternative hypothesis being correct? That is the question we are interested in. P-value doesn't tell you anything about that. Now let's consider this patient, young guy, end-stage renal disease on dialysis, gets admitted for cholecystectomy. And somebody in emergency, because he was found a little breathless, somebody did a tropi and it turns positive. Now specificity of this test is 95.9%. Assuming that null hypothesis, that boy doesn't have coronary syndrome, this result will be expected in 4% of the time. 0.04 is the p-value, and this will tell you that this patient must have ACS. But then it completely ignores what is the probability, clinical probability, that is pre-test probability of this patient having a coronary syndrome. So going back to our hypothetical trial, what we want to know is what is the chance that nephrologists and cardiologists are same. That's what we want to know. But what we get from p-value is what is the probability of your data if they were same. So in other words, somebody knocks the door and wants to know whether Mr. Jamale is there inside. So somebody else opens the door and say, I am Mr. Damle. I don't know where Dr. Jamale is. So that is the answer we get from p-value. Another problem with p-value is poor reproducibility. If it is 0.04 and less, there is almost only 20 or 30% cases it will be reproduced. We have created this arbitrary dogmatic separation. What if it is 0.04? What if it is 0.06? How does it differ? Actually, it will be a continuum and not a. So problem has become so worse that this esteemed journal has completely banned the reporting of hypothesis testing and p-value in there. So this is extreme step. Probably most of it will not be, most of the journals will not be following this, but then we need to understand that there are a lot of problems of interpretation with the p-value. It does not tell what we want to know. And we so much want to know what we want to know that out of desperation, we nevertheless believe that it does tell us what we want to know. So solution is rescaling p-value, means we can have a higher threshold, like depending upon the situation, means what stakes are there in that particular experiment. You can rescale the p-value from 0.005 or point, so that can be done. Very important, consider pre-test probability. That is completely ignored in hypothesis testing. what is the chance that this particular intervention or will work better, so and then modify acceptable type 1 error based upon the clinical context. I will come to this later because this is a solution for p-value alternative solution, but I will go through now how do we read the paper. I will take you through one or two examples. Which is this trial, nephrology? So this is Mentor trial, a famous trial of which brought in rituximab in the treatment of membranous nephropathy. So how do I start? Even before reading the trial, I start looking at who funded the trial, who sponsored the trial. There is nothing wrong in having funding for the trial. There is nothing wrong in having sponsor for the trial. If we start saying we don't want sponsor, we will not be able to do any trials. So most of the trials today are possible only because of the generous funding of the pharma. So funded by whom? That is not a problem. But what role funders have in the trial design, conduct, data interpretation and publication? So now here it was funded by Genentech, but trial was designed by the principal investigator. They were supported by, and this Genentech donated the rituximab. Okay. Also, I will like to know what are the ties between the investigators and the company. Now this is another example, sparsentan in IC nephropathy. This was the last year's publication, PROTECT trial. Here, Travera contributed to the study design, collection, analysis, data interpretation. So this is highly concerning. So what concerns me most here is data interpretation. Now this should be entirely the business of the clinicians or principal investigators who are conducting the trial and not the sponsors. Many times people will employ the medical writers to write the paper. Now there are 25 investigators. Not a single person has time to write the paper. So this is highly another objectionable and concerning fact. So medical writer funded by this industry also is another problem that I will try to look for. Declaration of interest, of course, how authors are related. Now, how do we go by the about the abstract? Now, I don't generally read the abstract at the first go. Only I read it in only 2 occasions. When because most of the time I want to know what exactly the trial, when I want to do a literature search and I want to know. And other instance when I will look at the abstract is when in the clinic there is a patient in front of me and I want to recall some data in terms of numbers. Okay, there is this risk, there is this benefit, this reduction. If somebody asks us, okay, what is the chance of this treatment working, what is the chance of, so that is another instance when we can refer to abstract quickly to find out the numbers. Now these 2 probably are the least important parts of the paper, because introduction we generally will not read because we know what is the reason that this study is done. We know, because as a nephrologist we know that there is an unanswered area, query, drug A works better or drug B works better. So that is the background why this study was done. Discussion is about what these people think about their results, and this is something that I think I will not read at least in the first go. I will go to it precisely. Sometimes we can get lot of understanding about the biases of the investigators there, the way they are discussing their results, and then we can come to, so that is another advantage of reading the discussion, but generally it is not very informative. The crux of paper is method and results. So this is what is the most important part of the paper, and I will carefully, very carefully go through each and every aspect of this. So whether study was phase 1, 2 or 3 trial, all of you are aware, preclinical laboratory investigation, then phase 1 will be done in few participants to check whether drug is safe. So if there is a major safety signal, drug's journey will stop there. If drug is passing this phase, then it will be tested in the larger number of human subjects to test whether it is efficacious and safe both. If there is no major safety signal and efficacy is there, then it will be tried in it will be tested in a phase 3 trial in relation to the active control standard of care that is being given, and at this time it will be submitted to the FDA approval generally, and after phase 4 FDA will be approved. You can see here that only 5% of the drugs make from the phase 1 preclinical to the FDA approval, and most of them are not able to get there. Drug failing at phase 3 is a financial disaster because millions of dollars will be spent in phase 1 and 2, and it's very important that these stages are very carefully conducted, and so that's to avoid this. Now, whether trial is superiority, inferiority, non-inferiority or equivalence. Now, equivalence trials are generally not done. They are only done in biosimilars when we are testing biosimilars. But generally they will be either superiority or non-inferiority. A word about non-inferiority design here. You can see here, this can be various trial designs. Here one is the point of no difference. So in non-inferiority trial, essentially what people will do is test a drug and try and see whether it is not very bad as compared to the standard of care. So what is the definition of not very bad? How bad is acceptable bad? So that is called as non-inferiority margin. So that margin is 1.2, or that is called a delta. So even if it is 20% worse than the standard of care, it is okay. Why should it be okay? Because this drug may be less expensive, this may be less costly, or it may be safer, because standard of care is very toxic. So you want to explore such alternative. So defining non-inferiority margin is critical, but unfortunately there is no consensus and there are no rigid rules for defining non-inferiority margin. But there are some ICH standards. I will not go into details of that, but they are not very standard. Now, random eligibility criteria. This is another very, very important part of the, and this will be many times in NEJM or Lancet will not have space to publish this inclusion and exclusion criteria in the main body of the paper. And Sahib will give you only the main body of the paper. So that's why many times we'll have to reach out to Dr. Khanna and get the supplementary appendix where we'll get details of inclusion and exclusion criteria. Now these are the inclusion and exclusion criteria of the mentor trial, and it is very important to know because the patient in front of you in the clinic, how well it fits into this criteria in whom the drug was pioneered and tested. This is a problem because sometimes these results may not be generalizable to most of the patient with this condition in the practice. And that is the very classic example of sprint CKD cohort. So this was a study actually done in one of the Italian clinics. Only 20% of the nephrology patients could match that sprint inclusion criteria. So how do we apply the guidelines based upon this trial to most of the patients with CKD? So if stringent inclusion criteria are there, results may not be generalizable to most of your patients. Sometimes they may exaggerate the benefits. Now randomization and blinding, now mostly it is not a problem. Gone are the days when people used to alternate patient to this and that and just toss up a coin. Now nobody does that. So that is usually taken care because trials are now conducted by the professional bodies of research organizations. So this is generally not a problem. End point is very important. We need to see whether clinical endpoints are the endpoints of the trial or they are surrogate endpoints. We will put more confidence in the trial which have evaluated the clinical endpoints. Essentially that means whether they have looked at how patient feels, functions and survives. Whether these endpoints are robust endpoints. So these trials will carry more weightage. Although there are not every time we can have these endpoints, and sometimes you have CR, PR, a reduction in the proteinuria, cyst size reduction in ADPKD, or acute rejection in transplant, eGFR slope, and so many criteria can be there as a surrogate endpoints. Now that is a problem with surrogate endpoints because you are aware of this trial TEMPO 3 for trial tolvaptan in ADPKD. So here significant difference in the kidney function was demonstrated with tolvaptan, and this led to approval of this drug. But this change in the kidney function corresponds to creatinine level increasing from 1.05 to 1.2 as compared to an increase from 1.04 to 1.2. The mean difference is 0.09 milligrams. So as we know, the creatinine measurement can have at least that much of a noise is not very uncommon with the creatinine measurement. So that's why these hard endpoints are important. Of course, this trial has different endpoint, that is cyst size as a primary endpoint, but then GFR endpoint may not be very robust. What is the control arm? What is this drug being compared with? Whether the control arm is what most of us will do to our patients against which this drug is compared. Now, is cyclosporine a standard of care? So that is a problem. But then let us okay. Now, how cyclosporine or control arm was treated? Now, this is from the Mentor trial again. Blood level will assess every 2 weeks until trough levels was achieved. If complete remission was observed at 6 months, cyclosporine was tapered and stopped over 2 months. Whether this will be done to most patients in your practice if you happen to use cyclosporine in membranous. So most of us probably would go a little more slower in tapering cyclosporine. At the end of 12 months, cyclosporine was tapered by 1/3 of the maintenance dose monthly and discontinued after 2 months. Again, this is something that many of us may not want to do, maybe go slower for stopping. And there was no surprise that less than half of those in remission at 1 year with cyclosporine maintained it at 2 years. Most of the patients after cyclosporine withdrawal came back again with the proteinuria. So this control arm probably was not the best, not received the best of the treatment, that is. Other thing is censoring. What do you mean by censoring? The patient was enrolled, but they were lost to follow. So censoring can be non-informative censoring that occurs in both the arms. For various reasons, patient may have lost to follow-up and may not be available for the analysis. But sometimes it may be a differential censoring or informative censoring. That particular study arm had lots of patients lost to follow-up, or control arm had lots of patients lost, and then it becomes a problem. So this is a Mentor trial. You can see in the follow-up, more patients in the cyclosporine arm discontinued the treatment. 11 versus 2 patients in the rituximab arm. And this is a problem because more patients, there is a differential censoring, there is a non-informative censoring. Also, this probably reason that they have lost to follow-up is there was 4 times higher incidence of adverse event in the cyclosporine arm, mainly acute kidney injury and other events. So that is the reason. We would have loved to have a comparator as a standard of care, which high-risk membranous. Standard of care, by the way, for membranous will be no immunosuppression in most patients and in many patients as a first line. But then in immunosuppression requiring patients, comparator would have been cyclic cyclophosphamide and corticosteroid. And in this trial, which was not a very large trial, but it wasn't realized that it was very toxic standard of care. This is the problem with non-inferiority trial, what is called as bio-creep. Like suppose A is a standard of care, then B is compared whether it is non-inferior to A, and yes, it is non-inferior, then B becomes a standard of care. Then C is introduced, whether it is non-inferior to B, and then C becomes whether it is a good alternative. So you can replace C with cyclophosphamide, B with cyclosporine, and C with rituximab. So that's how, that is called as bio-creep, that you are progressively accepting less and less effective treatment as standard of care as we move on. Many of you may be aware of this TRANSFORM trial. This is a de novo everolimus trial in kidney transplantation. And again here, example of censoring. Lots of patients in the everolimus arm had discontinued the treatment, maybe because of side effects or maybe because of higher rejection risk. So that is important to bear in mind. Most trial will report what is called as intention to treat analysis. That means patient has been assigned to a group and then finally is analyzed in the same group, whether or not it remains on the treatment or discontinues for some reason. And that is a reflection of decision, effect of decision to take path A versus path B, rather than actually you traveling all along the path or not. It prevents overestimation of benefit, but in non-inferiority trial, this approach sometimes can be a problematic, and you might also want to have a per protocol analysis. Subgroup analysis, this is important because subgroup analysis are most of the time not considered definitive answer to the question we are looking for. They are at the most considered hypothesis generating, but unfortunately this subgroup analysis became the basis of latest KDIGO recommendation about the target blood pressure in chronic kidney disease. This was a subgroup analysis of CKD patients from the SPRINT trial, and you can see here actually there was no statistically significant, although there was a difference, but in the CKD group there was no statistically significant difference, but guideline embraced this target. We were not happy. We protested, but I don't know what will. Another thing, important thing is harm. That is often not reported adequately and completely in many trials. Vague words will be used, manageable side effects or reversible side effects, non-significantly increased side effects, but this is something that our patient will want to know more about and will be bothered and interested more than the small difference in the outcome. And this is important to bear in mind. Now this is the NEJM original sprint trial, where in the conclusion you see the mention of harm. Rate of some adverse event was higher in the intensive treatment group, but in the CJSN article, which is a sprint CKD, there is no such prominent mention about the harm, when in fact there was increased incidence of various side effects that are attributable to the intensive blood pressure lowering. Same is with transform trial. Comparable incidence, though distinctly different pattern of adverse event. So there is no clear mention about the unequivocal higher incidence of side effects in the patient treated with the intervention drug. So you have to remember that statistics, although is important, it's not a truth machine. Scientists develop a hypothesis, put it to the test of destruction with Amrish Puri. But what survives this test is ultimately not the truth, but the best approximation of the truth. We have to understand it like that. And this is a disclaimer like mutual fund investments. In the trial, results are subject to statistical risk. Please read all the results, especially the terms and conditions and the existing knowledge. By that I mean the pre-test probability carefully before investing. Thank you.
What an amazing insight. Let me ask the chairpersons to share their comments. We have around 5 to 10 minutes.
Thank you, Tukaram. I enjoyed myself. I think you've taught me in the last 30 minutes, but I took 30 years to learn. So thank you for the revision. Fantastic, fantastic presentation. I'll just lighten the mood now. Thoda sa. So this was To Pee or Not to Pee, Act 3, Shakespeare. So what I would like you, if you haven't done it already, is to go through the American Statistical Association 2016 guidance on American Statistical Association guidance of 2016 on p-value that you can use for your next talk. This is from Professor George Cobb. So what does he say about p-value? We teach it because it's what we do, and we do it because it's what we teach. So that's the first point. The second point about Ronald Fisher, I'll give you a little bit of history. There is this book called Lady Making the Tea. Okay, now Ronald Fisher tested his p-value for the first time. Now there are various ways of making tea. You know, chai first, the patti, then the water and the milk, or the milk first and then the sugar, and different people make it differently. So he gave her 8 cups of tea, and she had to identify where the milk went first, where the water went first, where the sugar went first, and where the chai patti went. She actually got it right. So he actually tested it, and this is a book called as Lady Making the Tea. So you might find more jokes.
I will go through.
Alright. The scientific comments, just 2. Number needed to treat is for benefit, which you mentioned.
And harm.
It's for harm, and it's for screen. Or to screen something.
Diagnostic.
CPD, diagnostic. And the last thing is, if you have a paper with just the p-value, not the CIs and everything, test it using a fragility index.
Yes.
Yeah. When you test it using the fragility index, and if your p-value breaks quickly with the small numbers, then you know that the study has its problems. Well done.
Thank you. Thank you.
I really enjoyed your talk and Madam's comment here. Actually, when you talk about really many postgraduates might be there online and here also. So what happens when we give any data and go and get it analyzed from the statisticians, they come back, nothing is coming significant. So no p-value is coming. So everyone is bothering about the p-value. And as we have seen the comment of American Statistics Association, that I also wanted to make comment. And many of the journals have stopped, don't give p-values, don't write p-value. Even NEJM has recent instructions in many of the randomized control trials, don't write p-value. write your OR, RR, whatever you want to write, HR and 95% confidence interval. That itself gives you a lot of ideas about whether this theta values are really how appropriate it is and how correct. So that is the one comment that always we should think of. Rather, our students should know to analyzing and to knowing more about the 95% confidence interval, lower bound, upper bound, odds ratio, whether it is coming towards the lower bound, it is going towards the upper bound, or it is in the middle. So that kind of the interpretation should be known by all our residents. Then definitely, whenever you go about the presentation of the formulae, different kind of complex formulae, definitely we medical students or medical fraternity are very low, having low IQ, you can say, or you can say poor in mathematics. So we don't want to go into that jiggle. So
they get scared.
we are scared of getting this.
They get scared.
So definitely for that help, I will give suggestions that there are many calculators are there. That makes it so easy that sample size calculation, initially it was looking like you are going to your biostatistician gives this formula, that formula, you becomes confused, you will not be able to do anything at your home. But now you have the MedCal, you can calculate your own odds ratio, or everything that is all open, you can give your data and you can get within a minute on your own. So I think we should also start teaching our students how to use this MedCal, how to use this power, and how we can use this NCSS, how we can use SPSS, without going into the juggles of this calculations of you can go directly and you can get it that, and then writing this manuscript becomes should be the art. But actually, when we
Where is it all coming?
no, I'm just giving you a comment. Then it would be easy that they can, even knowing this, and they can write on the paper. And as they were telling, whatever you know, you should write. Whatever information about the case reports, case series, many data are lying there, people are not writing. Every information is important for medical fraternity, whether this is negative trial or positive trials. That's all from my side. Thank you.
I fully agree with what Narayan said. The students go to a statistician. The statistician has absolutely no idea what we are trying to do. So they'll come back with a bunch of papers with all tables and, they are at a loss to interpret it. We are at a loss to interpret it as well. So I've seen papers from CMC Vellore where there's a biostatistician involved and he is involved in the designing of the studies.
Yeah.
So right from that point, designing the study and then the sample size calculation, everything is done near perfectly. Like how intervention nephrology, nephrologists have started doing the intervention because they know best what is needed for the patient. Now we send it to somebody else to do it. He does something else and then he charges the patient, puts in a stent somewhere and then sends the patient back. So as Narayan was telling, probably under the auspices of the Indian Society of Nephrology, this should be part of the curriculum. The NMC insists that we should attend a research methodology workshop and it is being done. But how much the students actually gain out of this, we do not know. Most students are not really interested in knowing this at all. Most of them, their dissertations, they finish and then it stops there. So you made it very light and very, very interesting. And
Thank you.
as Madam mentioned, I learned a lot of things from you.
Thank you.
Thank you.
Yeah, brilliant. Which is why he's the chief convener of today's session along with Vaibhav and Manjunath. Today's entire program is designed by Tukaram along with Vaibhav and Manjunath, and I think we should give him. Thank you.